Hi, everybody. Thanks so much for jumping onto this video. My name is Dr. Nimit Jindal, and I'm a licensed pharmacist who is incredibly passionate about chronic disease management. And I'm here today to talk to you about an important class of medications that people around the world are taking to manage a condition called dyslipidemia. Now, in common terms, dyslipidemia, all it means is it's a condition where there's an abnormal amount of cholesterol in the body. So we've got a lot of things that I want to cover today. So why don't we go ahead and dive right in? So the first thing that I want to talk about is, what is cholesterol? Now, cholesterol is a substance that's found in our blood. It's something that all of us sort of need and require for daily function. So what I want you all to do right now is think about any assumptions that you might have about cholesterol. Usually when we read articles or when we see it portrayed in the media, there's usually a negative connotation or some sort of negative perception associated with it. We're always told that we need to find new ways to lower our cholesterol. But the truth is that cholesterol is actually a substance that we need for regular health. It's important because it is a prerequisite in building new cells. It's a prerequisite in creating new hormones, and it also helps with absorbing fats, which our body needs to do in order to survive. So the truth is that cholesterol isn't actually a bad thing. But like all things in medicine and all things in our body, the problem happens when we have too much cholesterol. And so that's really where the concern comes in. Now, what's unique about cholesterol compared to some of the other substances in our body is that our body actually has a way to recycle that cholesterol in a way that allows it to use enough of it that it needs. So essentially, because the body is recycling that cholesterol, you don't need to eat as much cholesterol in your body because there is a mechanism to recycle that and reuse that. And so because of that mechanism, because of that cycle, it's relatively easier for your cholesterol to get higher than something like, let's say, insulin or glucose, which you have to consume externally. And so this is why we really want to be focused on how do we control our cholesterol intake. Now, when we talk about cholesterol, we're not actually talking about one specific substance. So what's unique about cholesterol is that it doesn't dissolve in the blood like some of the other substances in our body. So the way it travels to our cells and the way our body is able to use it is when cholesterol binds with something called lipoproteins. Now, these lipoproteins basically just bind the cholesterol and take it to all the different components of the body in order for proper use. And so when we use the term cholesterol, we're actually using it as an umbrella term for these types of carrier proteins. So the first carrier protein that we talk about is something called low density lipoprotein. Now that's going to be the mnemonic or the acronym here is LDL. Now you all may have heard about LDL as the bad cholesterol. So this is the type of cholesterol that we want to lower, because if the LDL level in the body rises too quickly or too high, that's when the body starts to have all these sort of adverse effects related to cardiovascular disease. The second form of lipoprotein we talk about in cholesterol is something called high density lipoprotein, or HDL. Now, this actually is the good kind of cholesterol. So when we think about HDLs, we actually want to have a very high amount of this type of cholesterol in the body, because that's going to lead to all sorts of positive impacts of cholesterol, such as hormone development, cellular development, and fat absorption. And then the third type of lipoprotein we have is something called very low density lipoprotein, or VLDL. Now, this carrier protein helps to carry not just cholesterol, but also triglycerides, which are fats that the body may need in its daily course in order to function. And so again, if you have a proper amount, a lower amount of VLDLs, that's genuinely a good thing. But if your VLDL gets way too high, or it is beyond the normal bounds that the body needs, then we start to see massive amounts of fat deposits take place in the body. And this is when we start to see some of those cardiovascular events. And so all of these things together, LDL, HDL, VLDL, and triglycerides, they make up what we call cholesterol. And so when you're looking at lab results, or when you see the term total cholesterol, it's important to know that this term is a composite of all of these smaller subcategories of lipoproteins. So when we talk about cholesterol, I think generally there's a concern that cholesterol has some sort of impact in the body. We talked about the good benefits, the positive impacts that cholesterol has. But usually, as we see with our LDLs and VLDLs, is elevated amounts of those types of lipoproteins can put the patient at a significant risk of cardiovascular disease. So how does this happen? Well, as these lipoproteins are carrying cholesterol all around the body, in too high numbers, they can sort of form a plaque. They can pool together in the bloodstream and they form a plaque in the blood vessel. This deposit or this plaque hardens over time, and that forces the body to sort of try to push as much blood volume through the vessel, but it has a smaller surface area because that plaque is blocking the natural flow of blood. And so what this forces the body to do, it forces the blood to work harder, to move faster, it increases the pressure, but it also forces the heart to work harder to get blood to all of the necessary organs and tissues in the body within the same time. And so because of that, that's when we start to see issues like heart attacks, strokes, aneurysms. And this is why patients who have high cholesterol sometimes will have all of these secondary cardiovascular events, or in the worst case scenario, death. And so it's because of this reason that we want to take our cholesterol seriously, because we want to avoid some of those long-term complications. And so again, when we think about what are the key offenders here, well, it's going to be too high of a total cholesterol, too high of your triglycerides, if your LDL is too high, or if your HDL is too low. So a reminder, we said that HDL is the good kind. And so if that falls too low, then you don't have the good cholesterol that's combating the effects of the bad ones. And that's when you start to see some of these adverse events taking place in the body. So when we talk about these causes of dyslipidemia, I think it's important to know, well, what causes it? What are some of the reasons that people will have these abnormal cholesterol values? And so what we do know is that there are two main reasons why patients will have abnormal cholesterol values. The first one is called primary dyslipidemia. And usually our patients with primary dyslipidemia, they usually will have it because of some sort of genetic abnormality. So it's a family trait, it's a genetic trait that's passed down. And so when you go to your primary care provider and they ask you a question like, does someone in your family suffer from high cholesterol? What they're trying to gauge is there any sort of genetic risk that you have because of a family member? And usually with these patients, they'll have earlier signs of cardiovascular events. They'll have earlier signs of other comorbid conditions that we usually see with high cholesterol. And so that's how we kind of get a sense of if these patients are primary in nature. The second type of dyslipidemia that we have is something called secondary dyslipidemia. And with these patients, rather than it being genetic in nature, this is usually because of some kind of risk factor or some sort of lifestyle action that we can sort of point to. And so in these patients, usually we'll see certain medications that raise the risk of dyslipidemia. We'll see patients who are obese, who have poor diets, lack of exercise, patients who smoke. Smoking is a huge trigger for a lot of conditions, including high cholesterol, as well as other comorbid conditions like type 2 diabetes and hypothyroidism. And so these are just sort of some of the risk factors that you should be thinking about to think, am I at high risk, or is high cholesterol something that I should be particularly concerned about? Now, when you go to your primary care doctor, usually, and you should, get some sort of lab work done. This could be as little as once a year to a couple of times a year. And in your lab work that the doctor is ordering, or your primary care doctor is ordering, one of the things that they're looking at is your cholesterol levels. And so while this might not be something that you readily have access to, or this might not be something that you can easily check in your home, like some other chronic disease states, I still think it's really important that you're aware of what these numbers are and where they should be. And so what we use to measure cholesterol is we have two terms. We have milligrams per deciliter, and then we have millimoles per liter. And so milligrams per deciliter is usually a terminology or a unit we'll see here, we'll see in the United States, whereas millimoles per liter we'll see in countries outside of the United States. So this is just a little bit of where that terminology differs. But in our total cholesterol, what we're looking at is a number below 200 milligrams per deciliter, or 5.1 milliosmoles per liter. In our LDL, so again, this is the bad type of cholesterol, we want to keep this number below 130. Or 3.3 milliosmoles per liter. If you have a higher risk, so let's say that you have a genetic history or you have one of those risk factors, or if you've already had some sort of cardiovascular events, we're going to want that number to be a lot lower than 130. 130 is just sort of the starting mark. For HDL, again, this is our good kind of cholesterol. We're actually going to want to bump this up as high as we can go. And we've seen in clinical studies that the goal or the target for this really differs depending on your gender. So for men, we like to see this number above 40. And then for women, we like to see this number above 50. Non-HDL cholesterol, and so this is going to be usually our measure for VLDL as well as LDL. We're going to want to keep that number below 160. Again, lower if you're at higher risk. And then for triglycerides, which again is just the fats that are being accumulated in the body, we want this to be below 150. So again, this is not something that you're necessarily going to have ready access to unless you unless you communicate this with your provider. But next time you're at your doctor's office for a visit or for a checkup, ask to see your lab values, and you'll be able to see where do your lab values compare to what your targets ought to be. So now we can go ahead and talk about this major class of medications called statins. And so statins, by far, for most patients, are going to be the drug of choice. And the reason why they're the drug of choice in patients with abnormal cholesterol is because clinical studies have shown that they not only reduce the risk of cardiovascular disease, but they also reduce the risk of death in patients that are taking them. And so again, these are both very desirable outcomes for patients who have high cholesterol, just given some of the risks that these can go. And so the reason why we call them statins is when we think about the class of medications that this includes, they'll have something in common. So our common medication classes are, common medications in this class are Lipitor, or the generic name atorvastatin, Zocor, the generic name simvastatin, or Crestor, the generic name rosuvastatin. And so what you'll notice is the ending to each of those generic medications is statin, statin, statin. And so this is why we call this class of medication statins. Now, essentially how they work is they stop the production of cholesterol in the body. So if you remember from earlier on in this video, we talked that the body has a natural recycling pattern. And so that's helpful because it allows it to efficiently use the cholesterol that you're taking in. But generally through the course of our diet, we're going to eat cholesterol because that's common in our foods. And so what statins do is they prevent our food from being converted into cholesterol. And so by limiting that step that allows for the conversion from our food to cholesterol, we're able to bring down all of our total cholesterol levels, specifically our LDL or our bad type. Now, the one thing I want to keep you all aware of or notate is that statins are not always going to be the best class of medications. And like all things, this is a conversation that takes place between you and your provider. And so what I am cautious about saying in terms of statins being the drug of choice is that there are specific patients for whom statins are not indicated for. And we'll go ahead and talk about this in a few slides. So the first part that I want to talk about is, well, who are statins indicated for? And so there are 4 categories of people that we generally want to use statins for. The first one is anybody who has had any sort of cardiovascular event or episode in the past. And so these are going to be people who have an active diagnosis of heart disease, patients who've had a stroke, patients who've had peripheral artery disease, and then any patient who've had an aneurysm. And so because the risk of having a secondary event is higher for patients who have already had a primary event, we're going to go ahead and use statins because, again, the clinical studies have shown that they reduce the risk of cardiovascular disease as well as reduce the risk of death. The second group of patients that we're going to want to use this for are patients who have a very high LDL. Again, this is the bad cholesterol that we want to bring below 130. And so if you have very high numbers, we're going to try and target this early by prescribing those patients a statin. The third class of medications that we're going to use statins are patients who have any sort of other comorbid conditions. So again, this is going to be patients with those thyroid conditions, patients with diabetes, and then who have a LDL that's higher than the desirable target. So again, we want to mitigate those risks of death. And we know from secondary diagnoses that having a comorbid condition increases the likelihood of some sort of cardiovascular event as well as death. And then the last category of people that we're going to use this medication in are, again, patients who have a slightly elevated, but are older. And the reason why is because when we're older, there's all sorts of changes in the body, especially as it comes to blood flow. And we don't want to unnecessarily have the risk of death or cardiovascular events increase in that patient population. So we talked about who it's indicated for. Well, how about the people that they're not indicated for? So who shouldn't be using statins? Well, there's a list of patients that we say statins are not routinely recommended. And so the first one is patients who are experiencing some sort of liver disease. So again, if we remember back from earlier in the video, the body recycles our cholesterol that it's taking place. And so the two organs that are predominantly doing the heavy lifting here are the liver, and we have a lot of, the gut has a significant involvement as well. And so our gut and liver are doing a lot of heavy lifting. And so if you have an active liver disorder or some sort of condition that affects your liver, it's going to affect your body's ability to recycle cholesterol and process all of the body's mechanism. And so if you have active liver disease, we don't want to put statins in that group of patients, particularly when some of the side effects can exacerbate liver damage in the first place. The second group of patients that we want to be cognizant or think about is pregnant patients. Statins are incredibly, they have significant side effects on a developing fetus. And so if you are pregnant, definitely want to avoid statin use within that patient population. The third one, by extension, are patients who are breastfeeding. And then the fourth category is patients that are taking certain medications that interfere with statin metabolism. So as I'm sure you all know, all medications, when you take them, the body is going to act on them in some way. There are specific enzymes that act specifically on statin medications. And so if you're on a medication that is going to affect the body's ability to break that medication down, it's generally not recommended that you take the statin. Either we find you another medication to control your cholesterol, or we change the offending medication that is affecting the body's metabolism and then put you on a statin. So there's a little bit of puzzle pieces that we have to fit in order to get this regimen just right. Now, I talked a little bit about some of the side effects associated with statins. Now, the one thing I want to emphasize is that statin use in clinical studies has been shown to be both safe and effective. So the benefits are going to outweigh the risks. But like all medications, there are going to be some inherent side effects. And so based on these studies that the manufacturers have done and clinical trials, there are a couple of side effects that I want to make sure that you all are informed about. The big ones that we see are usually related to muscle pain and muscle soreness. And so these are going to be a lot in our bigger muscles, our arms, our back, our legs. Generally, patients who start taking statins for the first time will experience some muscle pain, some muscle soreness, but usually after taking it for a couple of weeks or months, that pain and soreness will usually go away. We also see patients who have diarrhea, and we also see patients who will have some sort of slight confusion. Again, like all side effects, these are natural. They happen with all medications. The real problem happens when these side effects interfere with the patient's ability to live a normal quality of life. And so these are the things that you want to have that conversation with your pharmacist or have that conversation with your provider about to see if these things are affecting your daily life. Now, there's one side effect in particular that I wanted to raise your awareness on, and that one is called rhabdomyolysis. Essentially, what rhabdomyolysis is it's muscle breakdown. So this is when we go from a common side effect like pain or soreness to the muscle literally breaking down. And so that leads to a massive amount of pain. And as you can imagine, that will drastically affect a patient's quality of life. And so for these patients, we will almost always take them off of the statin and try to find an alternative medication to control their cholesterol. But as I said, that one is also particularly rare. And so these are conversations you're just going to want to continue to have with your healthcare providers to figure out how you can best manage your condition and live a normal quality of life. So what else is it that you need to know? I know we covered a lot, and there's a couple of things else that I wanted to tack in here as it relates to statins. So statins generally are not going to be the only thing that we do to manage cholesterol. Like with most of our conditions, and we talked about it as a risk factor, we know that bad eating, poor diet, and lack of exercise can increase the risk of cardiovascular events, can increase the risk of making your cholesterol become even more abnormal. And so if we're going to use statins, we're going to almost always use it in combination with healthy eating and exercise. So you can't just say, I took my statin today, I don't have to do all of these other important lifestyle modifications that are required. Again, if you feel muscle pain or soreness that hurts more than usual, and you're worried about muscle breakdown, that's a conversation to have with your pharmacist. That's a conversation to have with your provider. And so make sure that you're communicating as those things come up. Statins, what's also unique about statins is that because the body reacts or breaks it down in a specific way, some statins actually have to be taken at specific times of the day. Usually with these statins, we'll see that they have to be taken at nighttime. So if you have a medication that you are supposed to take at nighttime, take it at nighttime every day, like you're being asked. The flip side is, what if I'm on a statin that doesn't specify? I look at my bottle and it just says, take 1 tablet by mouth once a day. Well, if that's the case, usually you're going to want to take it whatever time is most convenient for you. I know as a pharmacist, I always tell those patients to take it in the morning, because once you're done in the morning, you can kind of forget about it for the rest of the day. But make sure that regardless of when you decide to take that medication, you're taking it at the same time each and every day. It's not like you're doing morning in one day and then night the next day. Make sure you're consistent. You also want to make sure that if you're on statins, you avoid eating grapefruits or drinking grapefruit juice, because those affect with the enzymes that break down statins. And so if you're going to affect with the enzymes, it can lead to an unpredictable therapeutic effect that the statin is going to have on the body. And last but not least, of course, we talked about this as a risk factor. Make sure you're avoiding tobacco use. And so this includes all forms of tobacco. It's generally, tobacco will have a significant impact on your health in all settings, not just in cholesterol. So it's probably just good medical advice to say, not to use tobacco, or good educational advice to just say not use tobacco. So I know I covered a lot. There's a couple things that I wanted to just sort of summarize to make sure that you know that these are the key points of this video. The first thing is, make sure you know what your risks are. If you've already had a cardiovascular event, if you already have a diagnosis of cardiovascular disease or heart disease, make sure you're taking a cholesterol lowering medication. This could be a statin, or if you're not indicated, this could be another cholesterol lowering medication. But it's incredibly important that you're on something to control the likelihood of you having a secondary episode. If you haven't had that secondary episode, make sure you understand what your risk factors are. Is there somebody in your family that has had high cholesterol? Do you present with higher risk factors because you have type 2 diabetes, or because you have any one of the plethora of other risk conditions that we talked about in secondary dyslipidemia? If you know that you're at high risk and you want to avoid getting placed on a statin, the best thing that you can do is to make simple lifestyle modifications: healthy eating, exercising more, avoiding tobacco, making sure that you're maximizing the good fats, the good cholesterols, the HDL in this case. And then if you are on a statin medication, make sure you know those side effects. Make sure that you know that one of the common side effects is going to be muscle pain, soreness, diarrhea, and some sort of confusion. Those are natural, but only when they interfere with your daily life, your quality of life, does it make sense to have that conversation with your pharmacist or with a provider. And then, like all things, what are some of the things that you could do right now to avoid having to ever think about statin use if you're not on it if you're not on it, to avoid having to think about it in the future? Again, same thing: lifestyle modifications, healthy eating, lots of exercise, making sure you're getting your nutrition from vegetables, fruits, whole grains, high fibers. If you're on any medications, make sure you're taking them every day at the same time. Make sure that you're adherent and consistent. And then make sure that you're continuing to see your primary care doctor, or making sure that you're continuing to get those necessary lab work, those blood tests done, to make sure that your healthcare team can assess and track any changes, and then make interventions early before something more serious happens down the line. So I know we covered a lot. I hope this video was very helpful. Thank you all so much for taking some time. And again, if you have any questions about any of the content that we covered here today, you can go and log on to the Know Your Meds app and use the Ask an Expert feature or the Pharmacist Connect feature. And we'll go ahead and be able to answer those questions for you. So again, thanks so much for watching. I hope you have a wonderful rest of the day.